the majority of population in many countries in very, very near future. Imagine that if the majority of the population is unhealthy, they will unable to take care of themselves and less likely to continue to contribute to their communities and their country. So their well-being is an important factor that we need to take care of. So then effective programs to take care of aging adults' well-being are certainly needed. Take a look among older adults. According to previous studies, their major mental health problems are depression, anxiety, and stress, which they prefer psychological intervention to medical intervention because of side effects. These then may lead to lower positives and lower happiness in their daily life. And then it will contribute to increased risks of physical and mental illness. So then, previous studies have pointed to the need of preventative or early intervention, which are based on positive health model for this age group in particular. And early intervention is expected to bring about greater improvement and shorter period of treatment. So then, in this study, I propose psychological intervention to promote mental health and well-being using positive psychology and hypnosis. Currently, there is very scant research of this integrated approach for well-being enhancement, despite the fact that they complement each other in both theory and in practice. And my study has two objectives. One is to gain an in-depth understanding of the participants' experiences, perceptions, and feelings regarding positive psychology hypnosis intervention. And the second objective, this one has been refined from the information in the poster. The second objective is to investigate the efficacy of positive psychology hypnosis and explore factors that support or obstruct the participants to be happy and flourish according to positive psychology theory. Now, before I continue on to methodology and methods, let me present you a little bit about the proposed intervention. If you take a look at the center of the poster, you will see PERMA model of well-being. This model is a positive psychology model of well-being, which consists of 5 domains to support people to be flourish. And just to clarify, flourishing is a complete mental health according to positive psychology. It is where people have a syndrome of positive feelings and functioning, which will support them to thrive and to build up their resilience. So it may act as immunity to mental distress. The treatment then will be based on this PERMA model, aiming to enhance positivity and psychological factors in these domains, these 5 domains, to bring about happiness and greater sense of well-being. The expected outcome is that although the participants might be facing age-related degeneration and stressful transition life courses, they will still be able to constantly enjoy their life, be happy, and continue to thrive and flourish. For the treatment process, the treatment will consist of 4 45-minute weekly sessions. Each sessions will be structured as of hypnotherapy theory and process. It will compose of hypnotic induction, positive hypnotic suggestion, and post-hypnotic suggestion. Now let's move to see methodology and methods for the study. Well, for this part, I have been developing them quite a lot after we met in the summer school and after I have submitted. If you remember, in my previous presentation in the summer school, the study was only qualitative before, and I was considering adding a bit of quantitative to make it stronger. And now my research will be a mixed method study where a randomized control trial will be conducted. Two treatments will be compared. The experimental treatment, of course, is positive psychology hypnosis, as I have just explained to you. And the other treatment will act as a control condition, which I will use mindfulness relaxation. For mindfulness relaxation, is the process that a therapist guides a person to focus on their breath and relax their muscles. It is quite similar to the hypnotic induction, but there will be no hypnotic suggestions. So back to the methods. The mixed methods will allow, I expect that it will allow the study to gain in-depth understanding of the treatments of the intervention experiences for further development, and also investigate the efficacy and provide some statistical evidence for the intervention. For participants, there will be 40 older adults. In the poster, it says 22, but I have just increased it to be 40 because it will provide a more meaningful quantitative analysis, and I have calculated that it is still manageable in a reasonable time frame. Anyway, 40 participants is considered to be a very challenging number for this study because the treatments need to be delivered individually. Well, all the participants will be recruited from residential care homes and local communities in Bath, and then they will be randomly assigned into the two groups, 20 for each. For quantitative methods, data collection, I will collect data by questionnaires once before and once after the intervention. For the first questionnaire, it will be Oxford Happiness Questionnaire. This questionnaire will measure the participants' subjective well-being and happiness. And the other intervention, which is different from the one stated in the poster, it will be depression, anxiety, and stress scale, 21 items, or it is called DASS-21. This one, DASS-21, will measure the participants' negative emotional states of depression, anxiety, and stress. I am expecting that these two main questionnaires will provide different aspects of the participant's psychological state. The Oxford Happiness Questionnaire is to see if positivity increase, and the DASS-21 is to see if negativity decrease after the treatments. For quantitative data analysis, pre- and post-intervention scores of the questionnaires will be compared within group to see whether there is any development. Also, the results of the two groups will be compared to see whether there is any difference between the testing treatment and the control treatment. And for qualitative it will be multiple cases study where 5 participants from each group, so 10 in total, will be interviewed once before, once after, and once follow-up 4 weeks after the intervention process. So there will be 3 interviews. All interviews will be semi-structured. And the data will be transcribed and then analyzed by interpretative phenomenological analysis or thematic analysis, depending on the nature of the data, to see themes of participants' treatments and perceived changes of their well-being in their daily life. So that's all about the methodology and methods. Overall, this mixed design is expected to support the study to achieve the two objectives that I mentioned, which are to gain in-depth understanding of the participants' experiences and to know the effectiveness of the intervention. Now, looking further on to relevance into practice, this study would add another layer to a preventative or positive care for mental health, especially in older adults. It would bring about another choice of treatment for both patients and practitioners. It would contribute to healthy aging and support evidence-based practice in therapeutic field. Well, at this stage, the next steps of the project are that I will prepare for ethical application, and I will look for suitable residential care homes and local communities that recruitment can take place. And I will also review and finalize the intervention details and process. Now, just to conclude, my study proposes a psychological intervention to promote mental health and well-being in older age group using positive psychology and hypnosis. The study aims to add another layer, another aspect to positive and preventative treatment for mental health care. And the mixed methods design will support the study to achieve its objectives. The study could bring about useful information to take care of older adults that there are many risk factors related to their physical and mental decline. And as a researcher, I will make sure that this study is rigorous and reliable, and I hope that it can be one aspect to support people's health and happiness, which are important factors of their quality of life. That's all about my research project. Thank you for listening.
Okay.
If you have any comments or questions, I would be happy to hear.
Thanks very much, Nanis. That's a good presentation, and visually a very stunning poster as well. It's very well designed, very attractive.
Thank you so much.
I had a couple of questions really. One is, I suppose, about the rationale for the study, and then the other one is a methodological question.
Yeah.
But to start with the first one, it's not really clear to me what the rationale for this study is. Is it to look at people who are particularly at risk of mental illness, or if we want to, lack of well-being, or is the idea that this is something that's going to apply to everybody who's older?
It is the idea that to apply to anybody that is aging, that they are older adults, because older adults tend to have many risk factors anyway for their physical decline and mental decline. So as it is a positive intervention, I aim to apply to anyone, that is to enhance their well-being, their happiness, to act like an immunity to their decline.
So it's almost like a kind of vaccination against future misery then, is what you're trying to achieve.
Yes, actually, you can say that, because I am expecting that it can enhance their resilience to negativity.
But that causes a slight confusion in my mind, because if they're already okay, and this is to protect them against something that occurs in the future, then how do you measure the outcomes of the intervention? Is it just, I mean, if you vaccinate someone, you can see that their immune function has responded. What's the equivalent in this case? Or are you just going to wait and see how many of them suffer distress later on, or the ones that don't get the intervention? Explain to me how that works.
Well, actually, if I will have to wait to see if they face any distress and they can bounce back quicker or not. It will take quite a lot of time, and it will may enhance the time frame of the project. So it is actually, to be honest, it might be a limitation of this study, which is it is not like a long study to see their life in the future, but the two questionnaires, which is DATS21 and the Oxford Happiness questionnaire, it will measure if their happiness and their psychological well-being is increased or not, and that we can take a look at the results, and if their happiness increase, it may act as the immunity to mental distress, according to positive psychology theory.
It might, but it might not. Because I take the point that you could take people who have, median levels of happiness at the moment, give them the intervention, and they'll be happier at the end of it. I buy that. What I don't buy is the argument that you can generalize from that and say that will make them more resilient in the future, or that will have a protective effect against future problems that they might face, as they get older, and then the intervention fades in their mind, that somehow that will have some benefit. So you mentioned, that this will help with alleviate other health problems further down the line, and I wondered if you could say something from the existing literature, perhaps, that would persuade us that lifting someone's mood at a particular point in time can have that effect, potentially several years down the line.
There are some literature that explain that if people are happier, or if people are in the happy state of mind, they will live longer and they will tend to face the negativity in their life better. So yes, there are some literature that conclude in that way.
I think it'd be important to emphasize that in your thesis. And also, I think, I'm not saying you should include this in your doctoral study, because I know you've already got a lot to do with a mixed method study, but I think it would be very interesting to follow these people over time and see what their experiences are. I mean, the trouble is that they're quite small numbers, but and there will be attrition, I guess, because they're older people. But it will be interesting, postdoctorally, to follow up what happens to them and see if your theory is correct. Just one quick methodological question, and then I'll hand over to everyone else. You've decided to do an RCT now, or at least a pilot RCT, which I think is great. I'm really pleased you decided to do that. And you've got an experimental group and a control group, and the control group are receiving a mindfulness intervention. And I think both of those are interesting. I'm glad you've got that. But I wondered if you should also have a group that don't receive anything. So you'd actually have 3 groups, because mood can be shaped by broader things that affect everyone. So it will be interesting to see if there's differences in effect between your experimental group, the control group who receive the mindfulness intervention, and then just a group of people who don't receive anything. Would that complicate the study too much, or make it too difficult to do?
Well, if I am considering it like right now, I think that actually there is a reason why I do only 2 groups. It is because the intervention that as I mentioned, that the interventions will have to deliver individually, so it will take quite a lot of time for each person. Like 1 hour per person a week, which is very time consuming already. So the thing is, actually, as a therapist myself, I would like to deliver the best treatment for everyone, and I do feel guilty if I just don't let them get anything for another group.
I see what you mean. Yeah. I mean, I also think there's a problem that mindfulness itself is not a placebo intervention. It's it's a treatment. And so you trying to show a difference between your intervention and a mindfulness intervention is really making it quite difficult for you to show. You've got to show a better effect than that, rather than are better than no treatment. So
Yes, yeah.
it's kind of making it, it's kind of stacking the game against yourself, I think. But what other thing? I'm sorry, I didn't mean to hog the discussion. Can I bring other people in, see if they have any other questions for you?
Yes. Anyone have any questions?
Can I just ask Nanis? First of all, it's a very attractive poster that you presented to us, and I just wondered what the ethical considerations are around hypnotherapy.
What do you mean? In which aspect that you would like to know about the ethical consideration?
What do you have to provide in terms of hypnotherapy? Is it because it's, what effect is that having on the patient that it would need some sort of ethical intervention, or you'd have to gain ethics because you're using that? So when they ask you about,
pardon?
Yeah, so just really, what are the considerations you have to have when you're using hypnotherapy in terms of ethics?
Well, of course, I will let the participants know that the process of the treatment, and as I will be a therapist myself, and I have registered with the National Council of Hypnotherapy of the UK, and I will adhere to their ethical aspects or the ethical points that they emphasize on. Well, so in general, I will of course let the participant know the overall process, and they will be able to stop at any time, no matter during the session or after the session complete, whether the process has been completed or not. It is all up to them to continue or not to continue the treatment.
Okay, thank you.
Any other questions for Chinanis?
Can I come in?
Yeah, go ahead, Caroline.
Yeah, I've looked at the poster because I thought this was about critiquing the poster presentation itself. So that's what I've particularly looked at, and I just wanted to give you some feedback, if that's all right, Janice.
Yes, of course.
Yeah.
Yes.
I thought it was a really nice poster, and I thought it was easy on the eye. I liked the colours. There's a bit of an overlap on the top and the bottom, and I wasn't sure what that was. You used the word candidate at one point, and I thought it would be better if you used doctoral student rather than candidate, in your title. There was a nice picture at the centre. I like that, but there was a lot of blurring with that picture, and I wondered if you could kind of, sharpen it up a little bit or sort of spread it out a bit. I'm not quite sure. And I'm not sure whether this is this is pressing some of my buttons, but I just wondered if your pictures of older people were just a little bit stereotypical. They were either bald or they had grey hair, or and not everybody who is over a certain age looks like that. And there were a couple of spelling mistakes, and that was just a little bit of feedback there. So I might have got it wrong. I thought it was about how the poster was constructed, but anyway, if I've got it wrong, I'm sorry.
No, that's all right, Karen.
Thank you so much.
I mean, there are two things that are going off here. One is that we are going to assess Jananis's poster and her presentation of it, but we're doing that by kind of copying what would happen if you attended an academic conference. Yeah? So you present your poster, you talk about the content of it, and we have a discussion about that as we would if we were at an academic conference. So I mean, thank you for your comments, but I think what we really need to focus on is the content of the poster and the methodology and the background and that kind of thing. So sorry, just to clarify that. Are there any other questions for Chinanis, or shall we? Steve?
Quick one, sorry, from me, David.
Yep.
I really liked the poster, Nanis.
Thank you.
Clear headings. It's attractive. I think it would make me want to stop and have a look at it if I saw it at a conference, certainly.
I'm glad to hear that.
Just a quick question just around the recruitment of patients, and I wasn't sure whether you anticipated any ethical challenges in recruiting patients from the care homes. I'm just thinking about potential capability or capacity issues in recruiting that type of cohort. And also just I think the sheer size of the study now that it's moved towards a sort of RCT type approach, which is great, but I wouldn't underestimate what's involved in running, albeit even a small RCT. It's quite a big challenge, and just whether you'd thought these kind of things through.
Well, actually, in the old poster, I mentioned only the residential care homes, but because I am also considered about this point, so I have thought about recruiting the participants from local communities as well, and perhaps it will be only local communities that I will recruit. So I will take a look about this point first.
Great, thank you.
I think just to add to Steve's point, I mean, obviously, project management is going to be very important, and I think having a Gantt chart that shows the separate stages of data collection and analysis, and also has some contingency plans if you find it difficult to recruit from the sites that you've already got lined up. I mean, perhaps adding in other sites that you could visit to get participants from would be a sensible idea. But I'm sure that's something you'll be discussing with your supervisor and hopefully put in place before you commence the study. Any other questions for Chinanis?
Can I just very, very quickly just refer back to David's point about the RCT design, and I think David is onto something here. I don't know how far you've or how you've considered your control arms and intervention arms and so on, but I think you do need some way of separating out the intervention effect from a placebo effect. So and a control arm where there's no treatment is one way of getting into that. So I would support David in asking you to consider that. The other thing is that I wasn't quite sure what your inclusion and exclusion criteria were, and also how you're going to match the groups. Since this isn't a crossover design and the numbers are quite small, I would want to know how the arms how the arms are going to be matched to ensure that you really are comparing like for like.
Well, for the inclusion criteria, there will be older adults aged more than 60, and it will be 60 to 75, and have they must have not got any severe mental illness. And for the exclusion criteria, and the other thing is that they will have to understand English very well.
Right.
And for the exclusion criteria is that they are having severe mental conditions, having cognitive impairment, and have ongoing medical treatment for mental illness.
So the groups are not going to be matched beyond the exclusion.
Yes, I am going to say about this, as we will have the baseline assessment for the scores of happiness and the scores of depression and anxiety and stress. I am thinking about matching the two groups by these baseline assessment score.
Good. Okay.
Just one final thing, Chinanis. You've decided to do this study in Bath, haven't you?
Yes.
But you live in Thailand, don't you? So are you going to come over here to do this study? And I mean, why do it here and not in Thailand, I suppose?
Yes, I will go there to do this study. The first reason is because actually I would like to work there in the UK, and I am now in the process of finding some place to work there also. So, and the other reason is that my supervisor and practice-based supervisor is they are all in the UK. So I think it will be better to be near them in order to cooperate everything easier.
Mm-hmm.
And there is actually another reason. In Thailand, there are quite a lot of misconceptions about some kind of hypnosis thing here, and I don't want to make that misconceptions or bias to interfere in the study. So I think in the UK will be better.
Okay, well, good luck with that one. I mean, it's difficult if your entire project is contingent on being able to move here. I think. I mean, that sounds like something you need to resolve pretty quickly, which I'm sure you're trying to do. Anyway, good luck with it, and thank you for your presentation. Shall we move on to Stephen, who's next? If we can all scroll down to Stephen's poster.
It's Simon, I think, is it?
It's me.
Sorry, Simon.
Yeah, that's right.
Yeah, sorry, Simon. Do you want to take us through your poster?
Yeah, certainly. Well, just by way of introduction, my name's Simon Biddle. I'm a clinical physiologist at the neurophysiology department in Portsmouth Hospitals. And my study is about sequential pattern reversal, visual evoked potentials, pre, during and post dialysis, and that relationship to uremic toxicity in those patients with chronic renal failure. By way of introduction, really, the main function of our kidney is to remove excess water and mainly other excess waste units from the body. And gradually, with chronic kidney disease, that's a very slow process and can occur over a number of years. And then when we finally reach a stage called end-stage renal disease, and that occurs when kidney function has dropped to less than 10% of normal, and at that stage we can't contain and can't maintain life. It also means to say that we're producing little, if any, urine, so there's no urinary output at that time so that we can get rid of these waste products. And at the point of when we reach this end-stage renal disease, we would either need dialysis or a renal transplant to survive. The main method in the UK for dialysis terms is to use hemodialysis. And this is a specific method that we use to remove waste products, or also termed uremic toxins, from our body. And it uses a diffusion gradient of solutes across the semi-permeable membrane. So what we have is a dialysate which contains all of basically the good stuff, and that flows in the opposite direction of the blood, and that creates a very good gradient of which the dialysis can flow across. And the idea is there that we can correct the biochemistry of the blood over that time. In standard times for a dialysis period, it usually takes about 4 hours for that to be completed, and most patients are on a three times a week program for that. But what that does, that dialysis, it provides a limited correction, and what they've discovered was that even though people were being maintained pretty well on hemodialysis, was that this wasn't sufficient to prevent nerve damage or neuropathy, as the technical term would be. So it was believed that this nerve damage was caused by a molecule that was retained during dialysis, and that led to this theory called the middle molecule theory, which first came about in the sort of mid-60s. But as such, that's really not really been proved yet, and the whole point of it was around whether this was a slightly larger molecule that would take longer to dialyse out during that 4-hour period and was therefore retained within it, was toxic to the nerves, and that's why we've got the damage. But as I say, all the recent and subsequent research from that time in the 60s has still not been able to identify such a molecule. And then in 2004, there was an alternative theory from Hugh Bostock and his team that potassium is something that's retained, is not retained, but because it's 98%, approximately 98% intracellular, what happens is that as that's dialyzed, but as soon as you stop the dialysis program, that then floods back into the system. And what we've been able to show is that high levels of potassium are toxic to nerves, and they'll shift the gradient of the nerve, and so that potentially is damaging, and it stops action potentials occurring in that nerve as well. So from the graph that we've got on here in figure 2, this shows beginnings of dialysis and over the 4-hour period, and you can see a rapid reduction of the potassium down to normal levels. But as soon as dialysis stops, that immediately starts to rise again, and within 6 hours we're back to a toxic level. So that means that a dialysis patient will have toxic levels of potassium for the majority of the time, and this could lead to a potentially damaging effect on the nervous system. So whilst we've looked at, there have been potential sort of peripheral nerve studies which have shown that certainly there is a change physiologically with high levels of potassium. We've not really looked a great deal at central nervous system function. And a way that we can evaluate that is to use a test called a pattern reversal visual evoked potential. And that really presents the patient a visual stimulus, which looks like a checkerboard pattern. That reverses approximately 2 times a second. And by applying some electrodes to the cortex, and so the visual cortex is based at the back of our head, and from the picture on the poster, that's where those electrodes are recording from, and that records from our visual cortex and presents with us a waveform, which you can see in figure 4. And the P100 value of this represents the central conduction time. And what we use in evoked potentials is that N and P are representative of a negative or a positive wave, and then the figure after that is representative of the time in milliseconds. So what we're looking for is a positive waveform that occurs about 100 milliseconds. And we will have upper and lower limits of normal for those values. So in the past, previous studies have shown that there are differences between dialysis and transplant patients, and there are differences pre and post dialysis. And that indicates to us that there's a temporary neurotoxic effect, but that may diminish with time on dialysis, and so that suggests that there's a period where after which that damage to the nerve is not temporary, it's permanent. And so one paper suggested that perhaps after 2 years of dialysis that damage was irreversible. So the method we're going to use is to take subjects from a defined inclusion and exclusion criteria, to record the pattern VEP, and to record simultaneous biochemical measures which will include potassium pre, during and post the dialysis period. And so what this will represent is the worst metabolic state that the patient can be in, an improving one, and the post-dialysis period where they'll be at their best metabolic state. And we'll look to see if we can find a correlation between the biochemical markers of renal function, which again will include the potassium, and the central nervous system function that we can record from the pattern evoked potential. So the whole rationale about doing this is to show that the toxic molecule causing central nervous system dysfunction has still not been established. And the literature suggests that long-term dialysis leads to irreversible nerve damage. So we're looking to see whether if there's some intervention we can make prior to that, or some monitoring of levels of potassium or any other neurotoxin, to stop that irreversible nerve damage occurring. There are very few studies that are around that have actually demonstrated central nervous system dysfunction with respect to dialysis, and certainly none that have charted simultaneous potassium levels. And so in summary, really, the establishment of a neurotoxin that's causing that damage should facilitate increased vigilance and potentially reduce the irreversible nerve damage and subsequent treatment costs, and with improved quality of life to those patients. So in the future developments then are really to gain full sort of ethical approval for the study, to perform a subsequent pilot study and evaluate the need for that full study. If that's the case, then to go ahead, perform the full study, and then finally try and establish if there's a correlation between the central nervous system function and a toxic biochemical marker that we're recording from the biochemical measures that we're doing alongside those central nervous system function measures as well. So, in summary, then that's my project, and that's where we are at the moment with that.
Thank you, Simon. Again, very nicely designed poster, and thank you for putting it across in a way that even a non-physiologist like me could understand. Although, when you've heard my questions, you might think that I don't understand it very well at all. My first question is, it seems to me that this potassium molecule theory has been kicking around for quite a while.
Yes.
Is that correct? Since the 70s. I suppose my first question is a kind of why hasn't it been tackled before now question, which I know might be difficult to answer, but
yeah, well, I think it's the potassium theory has only been around probably for about 10 years. The middle molecule theory has been around since the 60s, and basically it just seems that they just taken it as read that would be the case, that it was just an undiscovered middle molecule that was causing this neuro damage, and they sort of seem to have settled for it. And it was only in the recent one, the paper in, say, 2004, Hugh Bostock's paper, which is one of the references I've got on the poster, is that they brought this idea to the fore, and they looked at a whole series of other molecules or toxic molecules that we get retained during dialysis, or that are in high levels, and they either found that they weren't neurotoxic, or to be neurotoxic they would have to be at such a high level that we would never see those levels in the human body. So in other words, urea is neurotoxic, creatinine is neurotoxic, but in such dramatically high levels that we'd never see that in a human physiological system. And a whole series of other ones that came about it. Another one they thought about was parathyroid hormone, but the problem with parathyroid hormone is it's not dialysable, and therefore there wouldn't be this temporary change because it's there all the time. Is a high level. So since that time, really, they've done a lot of work on peripheral nerve and shown that does have some effect on a temporary basis, and they've been able to do studies with people who have got very high levels of potassium and have been able to show that there's been a problem with the conduction speeds of peripheral nerve. But there's been very, very little work on central nervous system function, and I think it's difficult to answer why that hasn't been followed up, but I think it's just that they've concentrated on peripheral nerve and done a lot of studies on that, and haven't really followed up the central nervous system function at all.
Okay, thanks, Simon. I'm slightly concerned that someone might shoot your fox either by doing the study and publishing it, or showing that it's not a plausible theory anymore. But if you're confident that's not the case, then that's good. My next question, and this is where you may well think this is just stupid social scientists not understanding what you're trying to do, is about the design itself, because you're going to measure potassium levels and you're going to measure central nervous system function. Yes. And there's a kind of assumption there of causality, that it's the changes in the potassium levels that are causing the changes in CNS function. Yes. But I suppose my question is, there might be other things that are happening alongside potassium levels dropping during dialysis that could account for the changes in the CNS function. How do you control for that? How do you know that there's a causal link rather than just a correlation between these two?
I think all we can, what will happen is that it's not just the potassium that gets measured. When someone comes in for their dialysis, they always have a pre-test blood test to see what their function is, and that will contain a whole series of other values, including urea, creatinine, parathyroid hormone, sodium levels, and a variety of those things. And I think it goes back to what I was saying before, is that those other markers aren't neurotoxic, and it's a case of just being able to separate, trying to make a correlation between that potassium and the function. So although yes, it could be another cause of that, or is it something else in conjunction with it? But those measures are being taken as well. So we'll look at those too. But I understand your question is that can I be absolutely certain just because the potassium changes and so does central nervous system function change, is it the potassium that's causing that? And I think the answer is that we know that potassium does have a direct effect on nerve function. We know that some of the other standard measures of renal function and therefore their metabolic state don't cause, or those levels don't cause a neurotoxic effect.
Just seems a little bit circular to me that, you know, on one hand you're trying to show that there's a link between these two things.
Yeah.
And then as an explanation of why there aren't any confounders affecting it, you're saying we already know that it's toxic. So.
Well, we know it's toxic. We just don't know. We just don't know if that's if there's a relationship between that level and then the proposed level of change of the central nervous system function, or whether there's a clear relationship between those two individual markers.
Just one quick, and then I'll hand it on to other people. If you do manage to demonstrate this link, what can be done about it?
Well, at the moment, because only, if you like, toxic levels of potassium are tolerated within, because they'll assume that a renal patient has those levels. If they're very high, they're considered a medical emergency, because they potentially can put you into cardiac arrest, because the nerve that's supplying into the heart muscle will fail. You can get a variety of other sort of neurological side effects when you've got very high levels of that. So our idea is that, in fact, if we can prove that potassium, even at relatively what they might deem as being safe levels, in other words, it hasn't got up to a high enough level to cause these dramatic effects, but it's still having a damaging effect on those nerves. And so that can be corrected with other types of medication. They can add sort of bicarbonate into a person's medication regime, and therefore, keep those levels of potassium at a much normal level and a non-toxic level. So the idea is about raising the awareness of those levels and what they can do to them. And if their vigilance is raised, then they will be able to treat people better and reduce those levels using different types of medication and treatments.
I suppose if the bicarbonate thing works, then that kind of adds grease to your mill, doesn't it? That it is the potassium levels that are causing the problem in the first place. Yeah. Okay, I wanted to bring other people in. Does anybody else have any questions for Simon?
Simon, I think you probably know what I want to ask you, and it goes back to David's point. When I gave you feedback or we both gave you feedback on Unit 5 submission, I suggested that there have been some research in this area, and while neither David nor I are experts on it, it certainly seemed to me at first blush that there was evidence that you hadn't really considered, and I wonder now whether you've considered some of that evidence. For example, go on.
No, I think it was a very fair point, and when we went back and looked at that, the vast majority of it seemed to be around peripheral nerve function. And so whilst I agree there's been considerable work on that field, and they've certainly established that, what hasn't been done is the central nervous system function side of things. And so that's really where you know, our major sort of point was that yes, peripheral nerve, fine. We've established that yeah, if you change the potassium level, it will have a detrimental effect. You can have a short-term effect on that. Whether we've still established the fact that long-term, if you leave people long-term, or whether at what stage does that become irreversible? Again, I don't think we've established that and there's nothing to establish that in the literature. There's very little reports of how long people have been on dialysis before those effects are irreversible. So I think that's, you know, our main sort of take on that, and I'd certainly discuss that with my, you know, my work-based sort of practice-based supervisor, and that was his key point was, well, yeah, I agree, peripheral nerve, we're there. Central nervous system function, we're not, and there's been very, very little work on that, and very little work on about the length of time on dialysis and where we might be with irreversible damage and things.
Okay, thanks for that answer. So is your argument that there's something categorically different about peripheral nerve damage and central nerve damage, that there's something that we might expect there to be a fundamental difference here?
We might expect there to be a difference because the way that those nerves work are slightly different, and physiologically they're slightly different. So is that going to have the same level of damaging effect as it does on peripheral nerve as it would in central? So this is another thing we haven't really established as well. If we said, yeah, I'll take your point. If we said that peripheral nerve and central nerves were entirely the same, I would agree with you. And where would we be going? Because we've established that it's going to have that effect on it. But they're physiologically different, and the way that they function are different as well. So again, we don't know that effect.
My other point is that isn't there a standard protocol for dealing with this problem, that it's all about just keeping potassium levels, you know, within normal limits, between periods of dialysis, and so therefore, I mean, that's really the treatment, and that seems to be quite effective. So is there really a problem to be fixed in the first place?
Yeah, because what happens is that they are happy. Well, it's only when you've got extremely high levels of this potassium that you'll be effectively what they call a medical emergency.
Right.
When they monitor that level, they're happy that it might be in a toxic level, but because the patient's not unwell, that they're perfectly happy for those levels to be there. And what we're saying is actually it's not all right for those levels to be there. They need to be constantly measured and you know, or the vigilance needs to be increased, because you are causing damage, but in a slightly sort of in a way that you can't necessarily see or feel. So these people won't feel any different. They won't suddenly get funny tingles in their fingers or their feet or anything like that, or their eyesight won't change during that dialysis period, or even during the period where they've got relatively higher levels of potassium. But what we're saying is that most of the time they will leave those levels. They're quite happy for them to be relatively high, but not too high to cause them any obvious outwardly, or look at them and see if they're ill. So if they're happy for them to be like that, and our argument is, yeah, you might be happy because the patient's not unwell, but in fact, underneath that, there is a damaging effect occurring to the nerve because you're exposing the nerve for long periods of time to a toxic effect.
Okay.
Okay. Any other questions for Simon?
Yeah.
Oh.
Carolyn.
So leading on from that, if you already know that the levels are not right, that they're causing nerve damage, why don't we just give patients bicarbonate and that's it?
Because you've got to know what their levels are. For each individual patient, they're going to vary, and so again, if you speak to the renal physicians, they're not worried about, they don't consider it because a major problem, because they're saying, well, the patient's well, the patient outwardly looks well, we don't need to worry about that. And trying to adjust the bicarbonate, we've got to be careful as well, because if you give too much bicarbonate, reduce their potassium too much, and then they'll be hypokalemic. And if you've got too little potassium, then you get equally very bad, effects from that. So it's about individuality in terms of making sure that those levels are maintained. So it's difficult to give people like a standard dose, if you like, of bicarbonate or some other medication that will control those, act against the potassium level. So you've got to monitor, you've got to take those people on an individual basis and measure those differently.
Mm-hmm. So if the renal surgeons are not worried, because outwardly people are well, but inwardly there's some sort of nerve damage going on, but you clearly are worried, yes?
So what we're saying is...
So hang on a minute, so what is the aim then? Is this the aim to change the way the renal surgeons see these patients?
Precisely that. Is exactly that. It's to say to them, actually, whilst you might say that this is okay, patient's well, even though their levels are a little bit high, and we're saying, actually, no, it's not good, because long term this person's going to suffer irreversible nerve damage unless you monitor them better. So it's trying to highlight to the renal surgeons and to the renal physicians that in fact there is a damaging effect of potassium. At the moment they don't believe that. They may still be part of the middle molecule bunch that still think that there's some retained molecule within it. So Simon, sorry, is there any value in talking to the renal surgeons, doing some sort of kind of interviews with the renal surgeons, because surely they're informed, and this is a comment more than a question, surely you'd think they would be informed if this has been going on since the 1960s, they'd be informed by the literature. So would you need to go to them and ask them not why they're not informed, but what is their thinking around this molecule? I think, again, from the comments that we've had from some of the renal physicians that we've spoken to, it is, again, they're not worried about nerves. They're just worried about their person's renal health and their metabolic states. So as long as their patients are okay, I know it's a slightly, you'd think that they want to look at the care overall of their individuals. And I think if you want something to sort of compare that to, the number of people that have peripheral neuropathies, from nerve damage from who have got renal transplants is very, very high. And there's not a single clinic that looks after those particular types of people. If you go to a diabetic clinic, they have feet clinic and all sorts of clinics for those particular patients, but these ones don't seem to get that same level of care in those, or a more sort of global look at the way that they're looked, of their care package. So I think.
Sorry, is that universal or is that just in your area?
Oh, I think that's universal.
Okay.
Look in hospitals in general. Everybody will have a foot clinic for those diabetic patients, just because they develop a neuropathy as well. But also, if you look at the renal patients, they don't seem to have access or that same level of care. So I think it's about raising some, or giving the renal physicians in general some evidence that they do need to monitor those potassium levels more accurately and take a more sort of direct role in the management of those levels within their patients.
Okay. Thanks, Simon. Thanks. I thought it was a nice poster. I like the colours on it. It was immediately clinical. I would have liked to have seen the rationale at the beginning.
Okay.
So that I knew where it was going, but I like the way you took us through it very logically. Really clear.
Thank you.
Thanks.
I think we've got time for one more question.
Yes, I have just a little simple questions here. Personally, I don't have any knowledge about this area, Simon. But I just would like to know that do you include the patient's age and their general health level in your inclusion criteria? Because I am just thinking that perhaps people's bodies may react to the condition differently depending on their health and or their age.
Absolutely. So the inclusion and exclusion criteria is very much about age. It's about the time that they've been on dialysis as well. So one of our exclusion criteria, if you've been on dialysis for more than 2 years, we'll exclude you. And also, the other reason is that because the visual evoked potential relies on a certain level of visual acuity. So in those patients that who've got poor vision and that can't be corrected with glasses, then they will be excluded from it as well, because if they can't see the stimulus, then we can't get an accurate recording from them. So there are a whole series of reasons why we would exclude certain level people as well. So some of the age ranges are part of that. So we're not including children in this. It would purely be an adult study. It's unlikely to include people, in the elderly areas, because they will have probably neurotoxic effects anyway from life. We know that aging causes these things to happen anyway physiologically. So these are all parts of the things that, yes, we've put into the inclusion and exclusion criteria. So it's also based on their health as well. So their mental health. So they've got to have the capacity to be able to, for us to be able to record those responses that we want to. So in other words, that includes, if you're looking at a television screen, you have to concentrate on that screen for a couple of minutes. So it means to say that their mental capacity must be good enough to be able to understand what that test is about as well.
Okay, I think we're going to have to conclude that there. Thank you, Simon. You defended yourself very well there against some rigorous questioning, I think. We're going to take a little break now so that Alan and I can write up our notes and fill in the mark sheets. And then we'll be back at 11:15. So rather than close down the whole thing, if you just want to mute your mics and your videos, and we'll reconvene at 11:15. Please do come back, even if you have presented, because it is good to have a group of us, I think, commenting on these. So I'll see you again at 11:15. Thank you.
Thank you.